Hello, hello.
Hello,
Today
good morning.
we have our new podcast, and this is podcast with Carlos Bezos Daleske, who is CEO of Institute for Patient Experience. Hello, Carlos.
Hello, good morning.
And the name of our podcast is Patient Experience and Shared Decision Making. So we will dig deeper on topic of patient experience and what means shared decision making. And just to start, Carlos, if you can a bit present yourself, just to understand your experience and why do you talk about this topic today, and a little bit maybe about your institute.
Uh, Thank you, with pleasure. I come from the area of human reproduction, where I was quality director, and this leads you to patient experience. So, 2016, we opened the Institute for Patient Experience in Madrid. Meanwhile, after 9 years, we work in Spain, Colombia, Italy, Brazil, and Guatemala. We have started very little, but now I think it is the reference for patient experience, at least in Spain and Colombia, not told by us, but for instance, by the Spanish Society of Healthcare Quality.
Hmm. Wow, wow. It sounds very interesting. And if we start our topic, can you tell what is shared decision-making process in healthcare? What does it mean? Especially for those specialists who are maybe not from healthcare but are very interested. What does it mean? Shared decision-making process.
Well, we have several levels of shared decision making. Imagine you have something which is light, I don't know, uh, a flu, for instance. There we don't apply exactly shared decision making, but we can train the doctor, or the doctor can be trained so that he can involve the patient in understanding a little bit better his or her disease, her condition, and be aware of the decisions. Not just, okay, take this drug and wait 7 days until the flu is over, but that they become more conscious about what they can do actively. So this would be the very low level of patient experience, and we can scale that. Where does it make sense? It makes sense especially in chronic conditions where you have for your whole life a condition. For instance, when you have COPD, when you cannot breathe, and you need not only to have inhalators and certain kind of drugs that are not easy to take, but you have to take decisions on your lifestyle, like getting more movement, more exercise, and so on. So if you have just an approach as a professional, healthcare professional, of prescribing the drug and prescribing healthcare, patients have a chance of over 40% not to follow everything because they don't understand the reason. So they have to be aware of the consequences of not doing it, but not by fear, but because they are convinced that they want to. So here we use what we call patient-centered prescription. For a person that cannot that has respiratory difficulties, it is better. For instance, if they don't move, they get depressed. So it is better. Why did they get depressed? Because they don't have social relationships. It is better to address their need for social relationships. Like, wouldn't you like to see your grandchildren again? Or wouldn't you like to meet again your friends and go to the football every Sunday with them? Oh, yes, of course. So with that, we have like a motivation. If you have the motivation, then we can go. Then you should move more. You should take this kind of inhalator that will help you. So we have this second level for chronic diseases that appeals motivation. This is not exactly a shared disease, but here you can play with different drugs. Like this kind of inhalator is for better in this situation. This kind of inhalator is better in that situation. Why aren't you motivated to do more exercise? So people can try to share what are the barriers for that. Like, well, I feel lazy, or I feel sad. I really don't want to go out. So we can have a basis for a conversation with the people, with the patients, that can appeal to their intrinsic motivations to make a change in lifestyle. Then we have another level, which is really to choose between different kind of treatments. This is important, for instance, for cancer patients that where treatments are tested, of course, but they are very different and specific. So you need the patient to make a decision with you, because with if you take the treatment A, you will have certain benefits, but also certain side effects or consequences that you might lose your hair or whatever. You might choose between making a surgery or not, if it's not very dangerous. I don't know. It's really complicated things that it is better to engage the patient in that decision, because adherence will be better, engagement will be better. And if the patient is empowered and has the right level, he feels a part of his of the process of getting better. And this is very important for better outcomes.
Hmm. Understand. And who is responsible for this? Is it for me? What I hear right now, it sounds like the doctor just have some extra duties on him that he should support the patient not only from the medical perspective but also kind of from psychological perspective. Is it true or not? Or what stakeholders are involved in this shared decision-making process?
Yes, not only psychological, but also social. We have a case in Colombia which is very interesting with kidney disease, chronic kidney disease associated to diabetes. One of the key points is not only the drug treatment, it is that people for what we call social determinants, which is why we are sick because of social issues, like, for instance, men in Colombia with lower income, they when they work, they bring most of the income home. So what happens? They have a power position at home. So they are allowed to eat more and eat different things with more grease, with more fat, and with more carbohydrates. Okay, so in these cases, 15% of men of this profile don't have any effect by their medication, because they do the contrary of what they should be doing. So clinics, what they do is to engage the patients in general in not only share decision making, but support programs, so that people can be moved from the current position on I'm not going to take this change in my life to I should change nutrition, I should do more exercise, for instance. No, so but this particular profile, they don't go into these programs because it's not seen as something masculine. No, so this is a social determinant, and here it's where patient experience is very interesting. But once if you know that, you give the doctor the tools to address to this person in a language he can understand. Not only if you don't do this, you're going to die, which scares him and he doesn't go to the program, or this is what you should do because I'm the doctor and I order that to you. Often this doesn't work at all. No, so who is responsible for that? You have two sides. Of course, the medical institution, not only the doctor, the medical institution has to train the doctor for that. He has also to train and prepare the patients to enter in this kind of programs. And this goes step by step. You cannot have the medical knowledge a doctor or nurse have from one day to the other to make a shared decision making, or to understand that you cannot eat so many carbohydrates like in the language, because this person, it's not that he's stupid. Carbohydrates is part of the diet of this group since ages, since centuries. It is important to them. They are peasants, so it's energy. No, so it's not an irrational decision, but often the doctors don't know that. They think, oh, they are acting stupidly or irrationally, or they are not enlightened, or they haven't go to school, whatever reason. No, no, no. They are doing something which is very rational in a certain environment, but not rational from a health care point of view. So you need to train both. And also you need an instrument which is called patient-reported outcome measures. This instrument is a questionnaire that has to be written in a simple way so that the patient can understand it. So he can he can record the how he perceives his health, like he has pain or he has dizziness or whatever. No, so the doctor can use this to see how the patient is evolving, but also as a basis for a conversation. This is a way the patients gets more and more educated because if in every visit we talk about the same points and they are about health, every day I as a doctor can add a little bit more information. My patient can understand every day a little bit better. So it's not that I as a doctor have this level of language of knowledge and the patient this one. We get a little bit balanced. No, so we have to train the patients on one side. We have to train the doctor that get down, the patients to get high, and we need an instrument to have a common language.
That's very interesting. And if we talk about this common language thing, so as I understand, the patient, he wants to be healthy, but maybe he don't really understand what means healthy, non-healthy, and maybe he doesn't understand which criteria affects his health. And from other point, there is a doctor who knows only the medical, his ideology, but don't understand, for example, the values of the culture or the values of some emotional based motivation, which can be specifically for this dish, for this holiday, and person need to eat this a lot of carbohydrates just to feel himself belonging to this society, to this family. So when we talk about this communication, as I understand what you said, that there is one way is that the company or like institution or hospital should educate the professionals to be more like open for this. And from other point, we should develop some kind of a system which gives the feedback for the patient if he is going the right way or not the right way. Can you tell about
Yes.
it more? Is it like specific software? How do the patient get this information? Or it just every time the doctor told him based on his test, or what is the system? How do you do it right now in this
No,
number?
there are specific programs to train patients in that, so that and here we have several actors. The hospital itself, patient associations play also a very interesting role. And you mentioned technology. There are also online platforms, often financed by pharma companies, but often by the patient associations themselves, like patients like me. And they are validated. They have medical support, so it's not that a patient association says whatever they think. It is validated scientifically, and so we have these instruments: the patient association, the patient support program, or the patient education program of the hospital, and then the online platforms that are validated. Also, regarding the language, it is not that the doctor doesn't understand the culture or the patient doesn't understand exactly the implications for health. It is like we rationally understand everything. But it's like if I tell you smoking is bad, you will tell me probably yes, but you might smoke. Because our brain has a rational part, which is very powerful, but not very mighty. And the mighty part in our behavior is the emotional side, which is more the the one developed in earlier stages of evolution. So it's very powerful, and we work also by emotion. So we might know that we might change uh, lifestyle, but we might feel laziness. For instance, the doctor might know because he has read, but that patients maybe need another sort of language. But when he's under pressure because he has 10 minutes for patients and he has his whole education of being scientific, rational, use a certain language, then this emotional side of the doctor is stronger than his emotional side, no?
Yes, and this is a problem maybe because I was also thinking that you talk about so interesting system, but who will perform it? Because from experience that I have, and also having feedback from patient, for example, I did some research-based interview with American patient, and they told me very often that they don't have enough emotional support, that they just feed by a lot of facts, a lot of rules, and it's very fast, and then like go yourself, bye bye, come again after half a year. And then this person start to watch some health coach who tell him drink lemon juice and you will heal the cancer. And what he else have because he just opened the internet and internet just like in his mind. So how to deal with this problem? Yeah, because doctors, not enough doctors, not enough time. And same times, patient needs much more than doctor can give. What to do in this situation?
Often there are support institutions. For instance, I live in Spain, so there are the patient schools. The regional healthcare ministries have patient schools online or you can go physically, but they are almost online. So they create groups of whatever patients, respiratory patients, and they not only give the facts, but they give the emotional support and they make group work. This is very, very important for having a change in lifestyle. There are technological possibilities. There is an ongoing European project now called ROSIA that is on telerehabilitation for remote areas. For instance, imagine some lost villages in the Swedish north, far north, for instance, or small areas in Ireland, for instance. They cannot go to Dublin to the rehabilitation hospital. So they get this kind not only of technical rehabilitation, but of emotional and social rehabilitation, because this project is really, really interesting. You should look at it in the internet. It's not only about the technology, but for instance, if people feel alone because they are in remote areas and they don't feel motivated, imagine Sweden in winter, no? Maybe you're not very motivated to go out and make sports. They use, for instance, the local. Oh, sorry for the communities. No, they have their where the town hall is, and they put the rehabilitation system, the remote rehabilitation system, in the town hall, and there is a nurse, and there are other people like you. And so the social side, which is so important for rehabilitation, that you don't get demotivated, is provided not just by technology, but by the town hall that motivates the people, that gathers them, that makes a group. No, so this is one of the strategies you can use, and that comes out of this patient experience study, no, that was done before. So there are also patient support programs created by pharmaceutical companies, and many hospitals have this kind of programs, and many patient associations are very powerful in order to provide this emotional support. As I told you, in the United States, you have patients like me. You have in Spain these patient schools provided by health ministries. In Germany, you have patient engagement, and you have a very powerful association network, and which is maybe 80 years old after the Second World War, and they work really well.
Thank you. Yes, this is interesting. And when we talk about technology, I want to dig also more about that. Can you tell me about the AI? Now everyone talk about the AI. Let's discuss the topic AI for shared decision making. Have you ever thought about it using AI for shared decision making, or maybe have you heard about any system that using it? Any information about that?
Well, here we are now in a stage like when I was working in human reproduction in 2012. Doctors were very angry when they said another patient that read Google, no, because of course patients inform themselves and challenge the doctor, no, and now of course this has disappeared. Every doctor knows that patients have read something before and they are prepared for that. But now the same is happening with ChatGPT and so on. Patients are not also better prepared. They can ask questions to ChatGPT and it answers really, really well. No, so doctors are not prepared for that yet. I think we're at the beginning. Artificial intelligence has been used in medicines already for almost for 10 years. It's not new now, but I think the possibilities for shared decision making have still to be explored.
Yes, I agree with you because also it's really interesting that from one point that AI gives the opportunity to challenge the doctor, but from other point it also makes you more aware and you start to think. is it really good for you or not? Do you need to do it or not? Because I think what you talk about is that very important that the patient start to engage in his healing process, and this can be really good for himself.
One thing where you can use it is, for instance, for simulations. You can anticipate, and you can get even to personal medicine, but you can anticipate what a certain drug, what a scenario can be opened, and the patient can see that actually. The other point is that AI allows a very accurate monitoring. So if you go for a certain treatment that you have co-decided with your doctor, your data can flow very well into the artificial intelligence system, and the doctor can, and you also as a patient can see how it works, not only from your subjective feeling, no, it's like I have more pain or less pain, no, but what is happening inside your body. In this sense, it's very interesting. There is an interesting research based on PROM, these patient-reported outcomes in AIDS in Madrid, and doctors have a lot of information about all this, not only about the evolution of the disease, but all the other factors like psychological factors, depression, social problems, and so on that emerge. So they have a basis for this very good communication. So now this is done with a normal computer system, but imagine with artificial intelligence, it can be even predictive. No?
Talking about the predictiveness, can you talk more about the metrics or some system that help you to understand if this shared decision-making process is really better than it was or not? How do you measure this shared decision-making? Can you talk more about these metrics?
We have a case with a company we work for, which is a startup in Madrid called Insica. And there is this very interesting case in rheumatology where they crossed medical data on one side, um, patient-reported outcomes on the other side, economic magnitudes also, and patient-reported experience measures, PREM, which is very important because they measure the patient experience. It's not satisfaction, it's, for instance, satisfaction would ask you, are you satisfied the way the doctor communicates with you? And you say, okay, yes, because you had a good day and the doctor too. But imagine the doctor has a bad day and you too. Then you will value that from 1 to 10, maybe not 10, but 6. But if I ask you, did the doctor explain you the treatment? Did the doctor explain you the consequences? And did you remember what he told you? Despite the doctor was unfriendly that day, or you had a bad day, or you were shocked by the diagnosis and were not really listening, you will really, in a more accurate way, indicate if you understood or not. So this is a prem. So when you cross all this prom, prem, socio-demographic data, clinical data, here in this tool developed for the rheumatology department of the Hospital of Ramón y Cajal in Madrid, it came out, it was very clear that when there was shared decision making, which was measured by these PREMs, not only is there or not shared decision making, but how did they understand it, how did they apply it, and so on. There was not only better health outcomes, better PROMs, but there was a reduction in pharmaceutical costs because the use of the medicine was quite better. And it was not, I don't remember now the figure exactly, but it was not an anecdote. It was really significant. So there was a big difference between having a shared decision making, not in outcomes and in money, and not having it.
So, shared the decision making, it then help them to use less medicine and do some more lifestyle activities to develop, or what do you mean?
Maybe not less medicine, but better use of medicine.
Just more
Maybe,
clear timing, more responsible, more good diet,
yes.
yes, kind of combination of all, yes.
Maybe in another case, well, like the case I told you in Colombia, the use of medicine would rise and the cost of medicine, but the cost of having people with emergencies because of diabetes or the deaths that happen because they happen reduces. So you have to balance. Okay, I spent more money on that, but I save more on the other side, or I avoid the deaths, which is my purpose.
True, true. Um, we talk this about the positive side of shared decision making, but I want now ask you about some organizational barriers. Maybe I'm sure you have some experience finding these barriers where you want to start this and then something happened. Like, can you talk more about these most common barriers from
Yes.
your experience on shared decision making process?
We partner with the Hospital Vall d'Hebron, which is, I think, if not the biggest, the second biggest in Spain. They have 9,000 employees and a population of millions, no? And they have a really I would say, paramount example of shared decision making. And it hasn't been easy at all. I think they are a benchmark, at least for our region. I cannot say for the UK or Sweden, no. But they had difficulties. First one, it is not for everybody. Many people don't want shared decision making. Many people say, I trust my doctor and I don't want to think and especially if I am suffering something like cancer, I don't want to think about it. I want him to tell me what to do. So I trust him. This is, if not one barrier, at least something you have to respect. The other is if you start this kind of program, you, let's say, demand time from patients and doctors. They have to invest this time. And time, I think, is even more scarce than money. So patients are often work. So if they go to this kind of training, um, they they have to uh, break a little bit their working routines. They have to ask for maybe permission, or they have to break their family routines. They are not with their children, for instance. No, so this is a barrier. This is a real barrier, and this is why often many programs like those patient schools are online because then it is more convenient. At least people don't have to move. Now that we talk about movement, the other barrier is really physical. People in a bad condition or people that think that shared decision making is also for taking part in a clinical trial. And there are people that are really, their last hope is the clinical trial. So they are really in a condition they cannot move, or for them taking a bus and be 45 minutes and then go through not very accessible installations in hospitals, or people living in the countryside and having to move to the city. This is a barrier. So you have to take this into account. The other barrier is cultural. You have to make the program in a way somebody that is an engineer can understanding, but his grandmother too, you know, and his grandmother maybe comes from the countryside, and this happens often in Spain. Older people came from the countryside to the big city, and they learned maybe in school until the 14th year, and then they started to work. I don't know, of somebody cleaning. So this is the cultural level. So you have to address this cultural level too. And this doesn't mean that these people are less worth or they're not able to understand. You need another language to them and another cultural and social mindset. So this is another barrier for that. Then you have the complexity, not of the cultural level, but of medical know-how. Think that doctors take 6 years plus 3 to get this mindset, but you have to learn it very quick. Uh, you can learn it, but it's a process. It's not easy. So a doctor cannot tell you, no, this will help the cytokines to develop better. What is a cytokine? No, is it important? Do I need to know what a cytokine is or not? So you have to adapt not only your language to the culture, but what is important and what is not important. For the doctor, it is very important, but maybe for you, not. And then you have the organizational barriers. It's not that doctors don't want to. Doctors are really have a heavy work load and burden, not only seeing, I don't know, 40 patients a day, but they have to do research. They have to call you after. No, it's happened recently with an older patient that instead of being 10 minutes, she was like 1.5 hours, and the doctor then called the daughter. No, this is also work. And then they have their organizational work, their bureaucratic work, etc., etc., etc. So they are open to that from our experience, but you have to open a time frame and relieve them from other kind of work. And also you have to count on nurses. Nurses are also overloaded, but they are always undervalued, underrated, and they have a huge medical knowledge, and they have, I think, a very good approach to patients because they are not there to cure, but to care. So their language is different, their capacity of empathy, I think it's not that it is more, it is skilled. And they have been trained into that and they do it very well. So I would say nurses are key in any shared decision-making process.
Mhm. And when we talk about shared decision making, we now discuss the connection between the hospital, doctor, nurses, and patient, and maybe some patient associations. But I'm also interested about other circle inside the world of patient. Do you involve Is there any practice like that? Do you involve caregivers or family members to the shared decision making? And how do you do it? Isn't it a bit too much, or it's must, or what is this? Can you talk about it more?
It is very important to do so, especially in geriatric environments or cancer environments. Caregivers are very, very important, and they need also to be taken care of because they have the burden and nobody relieves them. So they not only need to know, I don't know, how to move an older person or how to administrate the certain medication or just to know what means heart failure and how to prevent it, no, with somebody who is frail, and the consequences of that. They also need relief for themselves, and they have burnout, and they need also to be trained in taking care about themselves and giving them also resources, psychological resources, emotional resources, other associations that take care of them, and so on. No, so it is you addressed a very important point.
Wow, it's also a big work in the future for healthcare, yes, but it sounds amazing because really, when we talk about health, health is not only doctor responsibility, it's like whole society interaction between each other in general, even yeah, starting from the government and coming to your family members, it's all affect your kind of health condition. Yes, it's.
Yes, one of the main drainers of health is work environment, because not only because maybe you work, I don't know, in a job that is dangerous. No, I'm not talking about that, or that you have stress. Is that there is a very low tolerance for being sick. For having a condition that is chronic, for instance, there are, for instance, I remember I was working at automotive years ago, and people that had hand eczema, for instance, and they couldn't move papers. The understanding of the bosses was very low, and the tolerance to that. They cannot fire these people, but suddenly they are seen as unproductive. In a work setting, very quickly the barrier appears: productive or not productive, useful or not useful, and people are easily classified. Clock, you are useless, no? And then now companies after the pandemic are a little bit more aware, but they can do far more for health with little, with little. Something maybe you cannot avoid stress, but you can avoid that it gets chronic, for instance. And this doesn't mean that you as a boss have to be like a father for your employees. No, but it has to be okay. This is a chronic thing. What this employee has, there is this program or there is this alternative, or I can negotiate with him or her productivity gains, like, okay, you are not going to be here for 3 hours, but how are you going to fix this, no? And people usually are open to this kind of bargaining.
Very interesting. And the last question I would like to ask you before we end is about conflicts. Is it possible when one side of shared decision making and another can have conflict and how to deal in this situation?
Yes, conflict is in human nature. Uh, Maybe it's not a conflict about knowledge. I know better than you because I read it in Google, for instance, no? But there can be, well, it's supposed, if you have a shared decision making, that you get to a sort of consensus between the patient and the doctor, and that you as a doctor inform the patient that he or she can take the decision and take them together with you. You don't try to impose anything, but maybe and you give therapeutic alternatives that are supposed to work, all of them. But conflict is unavoidable in human relationships. What we have seen in projects, for instance, is that people, you were talking about lemon juice before, no? And in some parts, there are social conflicts, like people prefer to go, like in Colombia, in certain mountain areas, not general, to old women receiving you or prescribing you herbs. No, for instance, this can be a conflict. But also here, young people listening to influencers telling nonsense, and they are more powerful than the old women prescribing herbs. But at least they are in a community. But the people in social media are not in a community, are not part of your life. So this happens sometimes, and it needs some diplomacy from the doctors and the nurses to lead this. Other conflicts can be conflicts of interests of the organizations. They buy a certain drug because they of price and of outcome, and they get the instructions by their health minister to buy certain things, and then sometimes it is difficult for doctors to prescribe another thing that is, but for bureaucratic reasons. Of course, there is always compassion treatment. There is always the possibility of have another thing. Nobody will deny it to you, but it can be a bureaucratic complication.
Thank you so much. It was really a nice talk, and I think all medical or tech professionals or even business professionals now can think about how to use this shared decision making in the benefits of their own health or their employees, or maybe they can have some idea of making a startup about that. Anyway, if you will feel that you need more information about patient experience, you can always contact Carlos Bezos Daleske, who is the CEO of Institute for Patient Experience. We will provide his LinkedIn link under this video. Thank you so much for your time.
Thank you for this very interesting questions and conversation.
Bye bye.